Hi there, this is Dr. Jess from Premier Physical Therapy, and I'm here today to talk to you about what can happen after breast cancer and how physical therapy can help you, okay? So, 4 topics that we're going to focus on today. One of the ones that we hear about the most is lymphedema, but that's not the only thing that can happen after breast cancer. Other things that can happen include shoulder pain, axillary cording, and myofascial pain syndrome. So this doesn't have to happen, but it might happen, and they are common things that can happen. So the more that you understand what they are and how we can help them helps to be proactive rather than reactive. And the goal is to educate and empower, especially women or men that are dealing with breast cancer. All right. Backstory, because we're going to go into lymphedema first. So the backstory of the lymphatic system. We have multiple systems in our body that help to carry fluid throughout the body, okay? So we've got the arteries and veins that carry fluid, and then we have the lymphatic system that carries fluid. Now, the difference between the two is that arteries bring oxygen to the muscles, and then the veins pick up the blood that we call deoxygenated blood and bring it back to the heart and the lungs, where the lungs were oxygenated again, and then it gets pumped back through. But there's not a lot of debris and crud that gets picked up in the veins. The veins are very picky little individuals. The lymphatic system, on the other hand, is a series of vessels that picks up anything else in the body. So this could be debris, it could be bacteria, it could be all sorts of stuff that needs to therefore be cleaned. So that's why we have lymph nodes. So lymphatic vessels carry fluid. The lymph node is where that fluid is filtered and cleaned. And then that fluid is dumped back into the heart, where it can return back into the main circulatory system. So that's how normal lymphatics work. And that's why we have lymph nodes. Whereas with the vascular system, the arteries and veins, we don't need nodes. So that's kind of the difference between the two. Now, why do individuals with breast cancer have an effect to the lymphatic system? And it might not be much that you notice, or it might be significant. But why does that happen? Well, when they are diagnosing and coming up with the stage of the breast cancer, they need to test the lymph nodes to understand if the cancer has spread outside of the breast. Because if it has, it's a completely different course of treatment than if the cancer is confined to the breast itself. So being able to remove a couple of lymph nodes and test them is completely imperative to coming up with an accurate treatment plan for your breast cancer. Now, let's say that we've got a couple of nodes that are positive, okay? Usually then they'll go ahead and start taking some more nodes to get a better understanding of the nature or the stage of that cancer. And so whether or not they take 2 nodes or if they take 15 or 20 nodes, there's still an effect to how that lymphatic system is going to function. And there's not a direct linear correlation to the amount of lymph nodes removed to the stress on the lymphatic system. Everybody is different, and everybody's ability to be able to accommodate to that stress is what's important, okay? And understanding that, and not saying like, well, I only had 2 lymph nodes removed, therefore I have no risk of lymphedema, but then why in the world is my breast on the lumpectomy side larger than the breast on the uninvolved side? Well, that could be fluid. Just because you had 2 nodes removed doesn't mean that you have no risk. But also, if you had 15 nodes removed, doesn't mean that you will present with it. It's just understanding that there was a stress to the system, and what can you do to decrease the stress and prevent onset of lymphedema if it is preventable. So that's kind of the whole goal. How can we be proactive? All right. Now, when we talk about what can go wrong with the lymphatic system, what we want to consider, okay, is when those lymph nodes are removed. Think about this. The easiest way that I can picture this in my head, and this is why I have the picture here for you, is a highway. A highway has lanes, and all the cars have to stay in lanes, and that's the flow of traffic. Well, think about that as your arm, for example, and you've got lymphatic vessels that are carrying fluids, the flow of fluid. Now, each lane has to pass through a toll booth in order to keep going. So each toll booth is like the lymphatic fluid passing through lymph nodes. Now, if you close some of those toll booths, you might close 2 toll booths, okay? And say you have 7 total. You close 2. You've got 5 toll booths left. So those 5 toll booth workers have to be able to sustain the same amount of traffic and keep it moving normally as it was when there was 7, okay? Now, sometimes they can, and they're fine, and it keeps going, but it is a more stressful situation than it used to be. Sometimes it's not. For what we are telling these toll booth workers is that you used to have weekends off, and you used to have 3 weeks of PTO a year. Well, you no longer get weekends off, and there's no more PTO. You're 7 days a week, and that's just all there is because we're not replacing the toll booths that we closed. So you will all now need to do more, and that's as simple as that. Well, what can happen over time is that you can have these toll booth workers or lymph nodes that are like, I'm done. Like, this is not okay. This is way too much work. And they burn out and they stop working. So now we're down to 4 or 3 or whatever it might be. And that's the whole reason why we want to decrease the stress on the lymphatic system prior to this happening, because we know that there's going to be more stress on the lymph nodes that are left. So we just want to try and give them some help and say, hey, we understand that you have more work on you now, but what we can do is we can decrease that burden. And that way we keep them working for as long as possible. So that's essentially what happens when lymph nodes are removed and then onset of lymphedema. And that timeline in between, when does swelling start, or if it ever starts, can be anywhere from days to years and years and years and years later. Every body is different. There is not, that's the whole point, there is not one presentation. All right, now, does early intervention make a difference? Well, I've got some research here that shows that it sure does. Like I said, if we understand those toll booth workers and we say, it's unlikely that these individuals are going to really take on this amount of work, this amount of increased work, and be completely okay with it for the next 30, 40, 50 years and have no qualms about it. That's a little unlikely. We can know ahead of time that they're going to want some help, and we can give it to them, and then we're going to decrease the risk of that lymphedema either starting or progressing into an advanced stage. So the study that we're talking about was a meta-analysis, which is a big deal, okay? They tracked 5 years of symptoms. So individuals that had early intervention, 5 years later, okay, the stage 2 to 3 just means a little bit more advanced stage of lymphedema. There's 30% of individuals, I said without early intervention. They had nothing done, just, kind of a wait and see approach. 30% of the individuals had stage 2 to 3 lymphedema. In comparison to same 5-year outcome with individuals that did have early intervention, only 6% of the population had stage 2 to 3 lymphedema. Stage 2 to 3 means that at that point it's not reversible anymore. And once we get to the stage 3, it means that we do have some fibrosis and some skin changing that has happened, which means that many times we don't necessarily get the limb down to the size of the other limb, the uninvolved limb. Usually that limb does remain larger. And that's the stage 3. Stage 2, a lot of times we can get them to be pretty equal. So 30% compared to 6%, I'm going to go ahead and put I would want to be in the 6%, in the group that's going towards 6%, meaning that I'm trying to decrease my chance of having an advanced stage lymphedema, and it's just early intervention. All right, how can I tell if I have it? Well, there's a couple things that you typically feel. You feel a sense of fullness or heaviness in the arm or breast, okay? It could be arm or breast on the affected side of the surgery where the lymph nodes were removed. You could feel like you've got a bracelet or a ring or a shirt or a bra or something just isn't fitting as well as it used to. A lot of times my patients will say they definitely can't put a ring on that finger anymore, or that the watch, the band that they used to put it on, like the little notch, now it has to be on a bigger notch, things like that. It's not typically a painful situation, but you might feel a sense of tingling, a sense of just the arm kind of feels different, but it's typically not painful. If it's painful, that's usually a problem. You might have an infection or something else going on. But true onset of lymphedema is typically not painful, just heaviness, fullness, some tingling, and things not fitting right. You might notice a change in the size of the limb. So usually what I tell my patients, okay, is I say, look in the mirror, bring your arms out to the side, and then look at that under part of your arm, this under part under here, and then look at the under part of the arm under here. And so when you're looking in the mirror, you want to see if one kind of falls down lower than on the other side, okay? So that's one thing that you can look for. The other thing you can do is check how things fit. The other common area that gets full is on the inside of the elbow. I don't know if you can kind of see that very well, but a lot of times I'll have them turn over and just look at that bend in the elbow on each side. And does that bend look pretty even? You can do it from here as well and just see, do I see a bony part sticking out? And then this one looks kind of flat and rounded versus bony. So you can check elbows, upper arms, and then also check on how rings, bracelets, shirt sleeves, bras are fitting. All quick screens to see if you have an onset of swelling. All right, now how does physical therapy help me? Well, if you already have swelling and we have measured your arm and we have noticed that there's a definite increase in the size of the arm, then what we need to do is we need to decongest the arm or the breast. Decongesting it is a number of things that play into how we do that. It's not just like squeeze in and just goes away. We do complete decongestive therapy, so it's called CDT. It includes manual lymphatic drainage, which is a series of skin stretching techniques that we use to stimulate the lymphatic vessels to pump at a faster rate than their normal baseline pumping. And so we can try and open up lymph nodes that were unaffected, so maybe the opposite side armpit or the same side groin, or use some of the lymph nodes that are along the sternum that weren't affected. And we're going to try and drive the fluid from the arm or breast to unaffected lymph nodes. And then we're going to try and increase what we call the lymph angiomotoricity, or the rate at which the lymphatic vessel pumps. So if we've got a baseline pumping of the lymphatic vessel, we want that to increase, which is going to kind of help to drive that fluid out of the swollen area and then filter through uninvolved lymph nodes. So that's manual lymphatic drainage. We do manual hands-on techniques for that. Then we also teach self-manual lymphatic drainage for the home program. We can also do compression. How we do compression oftentimes is with bandaging, short stretch bandages, to create a graded compression all the way from the fingers all the way up the arm, in order to apply a safe pressure to the arm to help that fluid work its way back out. There's alternatives we can do with using Velcro style garments as well if we've got situations where we might have contraindications to bandaging. There's all sorts of other options. There's never just one way we do it, okay? The other thing we also are thinking about is skincare. So making sure that you're using soaps that are gentle, using lotions that are gentle. Anything that's smelly and is perfumey typically is full of chemicals, and that can actually increase the dryness in the skin rather than improve the skin health. So making sure that we're really educating on proper skincare, infection control, all those kind of fun things is huge. And then exercises, because we know that when the muscle pumps and the muscle contracts, it contracts against the veins. And that can also help with some fluid return. But then we also want to make sure that we are using exercises to balance out any of the abnormal holding patterns that may have happened after surgery. A lot of times the pecs are tight and rolled forward. We might have some weakness in the scapular area. We may have some tightness in maybe the biceps or some of the muscles that sit along the rib cage. And we want to make sure that we're addressing that imbalance so that we can have a nice open shoulder, which is going to help that fluid come across as well. So we don't want to have a closed system here and compressing all the time, then being like, I don't know why your arm's not moving as quickly as we thought it would. Well, we got to keep that open. These are vessels. So we can't crimp down on those vessels and expect that they're going to pump as efficiently as we would like them to. So that's phase one. Phase one is getting the size of the limb down, back down to where we are either equal to the other side or as small as we can get it. And then phase two is the maintenance phase. So just because we get it down doesn't mean that it's just magically going to stay there. Remember, we have lymph nodes that have been removed. They are not coming back. So phase two is keeping it down. And this is where there's a lot of independence that's given to the patient and saying, okay, here's where you take it over now. So we use compression garments, we use a home exercise program, we continue with the proper skincare, self-manual lymph drainage, and we may be using a pump at home as well, which is going to be another way of doing manual lymph drainage. It just kind of depends on the severity and the stage and how much attention we need to give it in phase two. Sometimes phase two is a very simple plan. Sometimes phase two requires more attention from the patient. It all just depends, and it's all completely individualized to the individual that's coming in. All right, next topic. So that was one, that was lymphedema. So we've got 4 to cover. So number 2, axillary cording. This is an interesting diagnosis. It's still not completely understood as far as exactly why this happens, but it does. And this one does create pain, and it typically does create a limited amount of motion. So what we need to know is that axillary cording is a signal. Your body is telling you that your lymphatic system is stressed. So you might not yet have swelling, but your lymphatic system is in a stressed state. And so we need to be very mindful of that and make sure that we're also being proactive with decreasing the stress on the lymphatic system. When these axillary cords, okay, it's essentially just fibrosed lymphatic vessels get adhered, they can start to become painful when you put stretch onto them. So if I'm trying to move my arm and I'm raising overhead, I might feel a really strong pull from my elbow all the way to my armpit. And it's like, it hurts. Like I can't go past that. It is not fun. Then if I wanted to check and see if this was truly a cording issue versus a shoulder dysfunction issue, I could tension the skin. I could tension it this way or this way, depending on where the cord is present. And I'm going to see a little cord playing out. I'm going to see it. I'm like, oh my gosh, what is that? That is the fibrosed vessel. Okay. So how we deal with that depends on the individual. There's all sorts of techniques that we use to free up the fascia so that the layers of tissue can slide and glide a lot easier. There's techniques where we kind of do some stretching, techniques where we decrease the stress on the lymphatic system, improve the flow, and then we start getting some improved range of motion. So there's not one way of addressing this. You've got to be careful. Don't just go in and say, I'm just going to tension this and snap it, and then I'm going to feel 100% better without addressing the stress that the lymphatic system is going through, because then you could actually create some more damage. So this is important that it is treated by a trained individual that is managing your lymphatic health while also helping you with the cording. It's typically completely resolved, and we are able to regain normal motion. So that's the good thing about axillary cording. This isn't like a chronic thing where, like lymphedema, where we're asking you, okay, now for the rest of your life, we're asking you to manage this, whether it's with a garment or other things. This we can resolve. That's the good news. All right, here's some pictures of what axillary cording looks like. So you can see in this picture, we've got the individual that's got these bands that are visible when she's raising her arm overhead. It typically affects from the armpit into the upper arm, but it can progress all the way into the forearm or into the chest wall itself as well. That's not as likely as from the armpit to the elbow. So, but it's important to know, like, it can go all the way down to the wrist. That's a possibility. Now, with physical therapy, I kind of already mentioned this, that we do hands-on techniques to help the lymphatic system, okay? We're always thinking about lymphatic health, always, always, always. We want to mobilize the restrictions that we find, and then we really focus on safely regaining and normalizing shoulder motion. We are never just focusing on amount of motion alone. We've got a lot of other things that we're constantly considering to make this healthy for you, and so that you don't have negative outcomes like swelling. All right, now, so the third topic that we're going to talk about is shoulder pain. And I hear this all the time. So is shoulder pain after breast cancer the new normal? Is this just how I'm going to be? A lot of times individuals think that this is to be expected. It is the new normal, and that's just how it is. Well, my answer to that is no, okay? This is not the new normal. You need intervention in order to specifically address common things that can happen after breast cancer surgery or intervention or reconstruction or all of the things that you have or a loved one have been going through. So again, let's go to the data. Let's see, am I talking like and just making stuff up? Okay, I'm not. Everything we do in the clinic is evidence-based. We're not just hoping that what we do makes sense. We are doing things that are evidence-based. So what they have found is that, again, following individuals 5 years past breast cancer treatment, okay, if they did not, the females, typically females, sometimes males, did not participate in early intervention to normalize the shoulder mobility and range of motion, 43% of the individuals 5 years later still had shoulder limitation. 43%. I mean, we're almost pushing half the population, okay? That's a lot of people. That's compared to 9% of individuals that did participate in early intervention. So again, like, early intervention is so key to not only preventing dysfunction, but completely normalizing mobility and being able to return to a healthy, active lifestyle. Because there's no reason why you can't. Now, why is shoulder pain so common? Well, we have to consider a couple of different things. So we need to consider the muscles that surround the shoulder joint. Now, your surgeon went in and had to remove a tumor, remove lymph nodes, maybe help with reconstruction, maybe do a full mastectomy. So there was trauma to the area. Well, a lot of times muscles don't really love that idea. So muscles don't have a higher level of function where they're like, oh, this makes sense. This was needed, and therefore I just need to stay calm and relaxed about the situation. They don't think like that. All they know is, uh-oh, there's an incision. I should contract and protect and make sure that I don't let this area move because there's something wrong. That's all they know. So again, it's normal that they get tight and painful and start restricting motion. That's a normal thing. It's very common. The most common muscle is that muscle that you see that's deep in there. It's called the subscapularis. And then that other muscle that sits along the rib cage, your serratus anterior, and your pec. Very common that those muscles are quite tender and sore. And that's all treatable, which is the good news. Now, joint limitation. So the muscle might be involved, but the joint might be involved. So if you haven't been moving your arm as much as possible because of pain or, and there's you don't want to just move it right away when you've got, incisions that are healing and whatnot. So you should be progressively trying to get that moving. But the joint itself might start to get stiff. The other thing that could start to become immobile or stiff is the shoulder blade moving on the rib cage. So these are all things that, again, are very common that happen that we just need to get moving. That's all. And the last thing that we need to consider is scar tissue. So if I pull on that scar, okay, and it's healed normally and we have normal mobility, I should be able to move the skin in every direction around that scar without having any significant restriction or immobility. That happens sometimes. Some people heal really well with scars, but commonly some of the scar tissue starts to get a little bit adhered to the layers underneath. We start seeing some limitation, which then can start to tighten things down. So we might have a scar across the mid-back, depending on the type of reconstruction you had. We have a scar across the front of the chest. We have a scar underneath an implant. There's all sorts of different areas where there could be scars. There's scars from where they have the ports coming out or the drainage lines. And so all of those areas are areas we want that moving normally so that you can return to normal motion without impinging or creating tension on the rotator cuff or all of the different things that can happen with shoulder dysfunction. Now, how can physical therapy help with shoulder pain? Well, that depends on you. And that's why we always have an individualized treatment plan for each person that comes in. So when we do the evaluation, we're looking for everything. So we're going to consider the muscular system. We're going to consider the joint. We're going to consider the scar. We're going to consider the posture. We're going to consider the strength. And so all of that gets assessed, and then we come up with the list that's pertinent to the individual that's here. And so I'm not going to be, if you're really, really strong in all directions, well, I'm not going to be giving you a lot of strengthening exercises. If your scar is moving perfectly, I'm not going to be doing a ton of scar work. If your scar isn't moving well, then we're going to try and get that scar moving. If I poke on some muscles and you're like, whoa, that really hurts me, well, that's abnormal. So if I poke on my muscle, on my bicep, if I poke on that, I shouldn't jump off the table. That shouldn't cause pain. Okay, if I poke on a muscle and you're jumping, that's telling me that the resting state of that muscle is abnormal. It needs to be addressed. We need to calm that down. That's not fair to you to have that all the time. The other thing we might do is, like I said, the joint mobilization. So it all depends. But what we're looking for is to normalize not only the muscles, the joints, and the scars, but we're going to normalize what's called the scapulohumeral rhythm, or the rhythm and timing for how that shoulder joint and the scapula all work together. And then your shoulder starts feeling better, which is great, and you can return to all the fun things that you want to do, which might be something as simple as lifting a plate overhead. It might be something like returning to tennis. It's all based on the individual. All right. Last topic. We had 4 to cover. We're on number 4. Myofascial pain syndrome. Now, this is one that I don't think is discussed nearly as much as the other ones. So the other ones I think people have heard of a little bit more. This one people are like, what are you talking about? However, nearly half of women develop myofascial pain syndrome within the first year of breast cancer surgery. Half. So this is a big deal, and this is something that is really creating pain in individuals that does not need to be there, okay? This is something that we can address. When we think of myofascial pain syndrome, that's different than just a muscle being tight or weak or scar tissue restriction. When this happens, we have what's called trigger points that develop in the muscle. So trigger points are taut bands of muscle, okay? So if we have the muscle like so, should be overlapping pretty, like a nice overlap. It's not super tight, it's not super stretched. We've got a nice overlap. What happens in those muscle fibers is that we get a couple of the fibers that start getting a little bit stuck, okay? And when you roll over that muscle, if I go perpendicular to the muscle and I roll over, I feel like a little bump that kind of bumps underneath my fingers. What that is that that's a point in the muscle where it's remaining in this contracted state. And it takes energy for the muscle to let go. And it doesn't have the energy to let go, so it remains here all the time, at rest, when you're moving, all the time. Now, the key to a trigger point is that when I poke on that trigger point and I push it, is that it's going to refer pain to another area. So a lot of times people will think, oh my gosh, like it's not my shoulder that's bothering me, it's my wrist or something else. And it's like, okay, well, let's look at it, let's screen it. But I never make assumptions. We always go based on objectivity, because I know that trigger points are common. So, and I'm going to really understand my referral patterns that I'm looking for. And that's going to drive my awareness of when I'm palpating muscles of what I'm looking for. But the biggest thing you need to know is that a latent trigger point does not actively refer pain. So it's like, I don't have this pain all the way down my arm all the time. It's only when I'm moving or stretching in a certain direction, for example, okay? So that would be more of an active trigger point. So something that is A latent trigger point is when it's referring pain when it's touched or activated. Okay, so it's like I poke on something and I feel pain that radiates, or I use the muscle and it then the pain is worse and radiates. Versus that active trigger point, that's referring pain even at rest. It's there all the time. So either way is still a trigger point and it needs to be addressed. Now, the common muscles that are affected after breast cancer surgery. So I kind of touched on this a little bit before. That subscapularis, it sits on the front of the shoulder blade. So this muscle, again, it sits on the front of the shoulder blade, but it commonly refers pain to the back of the shoulder or into the wrist. And so it's like people are like, no, like, why are you poking here? Like, my pain is all back here. Well, just hear me out. I'm just doing my assessment. I'm collecting data. That's all I'm doing on the first day. I'm just collecting as much data as possible because, again, objectively, we are going to put together our treatment plan. So we don't just like chase symptoms. If the pain is here, therefore that must be the problem. No, not the case. Pec major. So one of the other muscles that gets really tight and flared up a lot of times after mastectomies or lumpectomies can refer pain to the front of the chest, but as you can see, it also refers pain down the arm and then down into the forearm. So you might be thinking, oh my gosh, like, I wonder if this is coming from my neck or if I'm having like something going like a pinched nerve, which it could be, but it might not be, okay? Rhomboids, that typically refers pain, but it stays around the scapular area. So that one doesn't move out so far, okay? Serratus anterior, this one sits along the rib cage, the muscle. And so the pain a lot of times is all underneath this armpit area, but it can go into the scapular area and it can refer down the arm and present like an ulnar neuropathy. So that's that pattern of the ulnar nerve kind of goes down to those last two fingers. A trigger point in the serratus anterior will also refer pain into a similar pattern. And we would be ruling in or ruling out nerve dysfunction as well. So we never make an assumption that just because I poke on this that the nerve isn't involved. So we still are going to rule in or rule that out by doing a cervical screen. And then the pec minor, just again, another pectoral muscle. It sits deep to the pec major. That one also can refer pain into the front of the shoulder as well as down the arm. So many times these trigger points can be really mimicking some other disorders that you might be getting like MRIs and all these things like what is going on and everything's coming out negative and you're like, maybe I'm just making this up or maybe I'm overplaying this. And then you come see me and I'm like, I poke on it. You're like, whoa, I can't believe that just reproduced my pain. I'm like, well, based on your history, like this is a likely diagnosis that you could be dealing with. All right, so overall treatment approach, we have an individualized eval to diagnose the presence or absence of active or latent trigger points, okay? We do hands-on intervention to treat the trigger points, and then we're gonna address the contributing factors to why the trigger points are there. So again, we don't just treat the symptom, we've got to treat the cause to why is it there? Why is that muscle still so mad and not calming down like it's supposed to? So it could be posture, it could be joint myofascial restriction, it could be scar mobilization. Is all of this sounding common to what we just talked about with the shoulder? A lot of the shoulder dysfunction goes hand in hand with myofascial pain syndrome. And so a lot of the co-treatment happens between getting the shoulder normalized and getting that strength balance back, getting the muscle length balance back to decrease the strain on the muscle that's developing the trigger point. And then we also treat the trigger point as well, or trigger points. All right, so let's recap because let's just like bring it back. So are pain or swelling inevitable or untreatable? No, okay, they're not. Can we prevent everything from happening? No, okay, I'm never gonna make that promise, but what I can say is that we can decrease the risk of having these things come up. We don't have to take the wait and see approach. We can be proactive and teach really good, healthy strategies for normalizing the shoulder range of motion. As you're healing, making sure that we've got the scar tissue moving well, that we've got the scapula moving well, and that we're being really nice to your lymphatic system, especially as you're going through potentially other treatments, other things that might be stressful, like radiation or progressing into a reconstruction surgery or things like that. We can help and make sure that we're keeping the system and the shoulder and the posture as healthy as possible, during all of this to make sure that we're doing our best to prevent things from happening. It's never 100% preventable. That's a bummer, but it is. That's the world we live in, okay? But we can do our best to do that. If you come in because you do have active swelling or active shoulder pain or myofascial pain syndrome, and we have taken the wait and see approach and we are now treating the condition that's popping up, that's fine as well. We can definitely handle that. The point of this presentation, though, is to say that we can handle that, but then we can also help try and prevent that. And that's the number one thing that we're trying to do, is get the word out that you don't have to wait and see. You can decrease your risk. We went over all that research. All right, take home message. To improve mobility, okay, is to decrease the economic burden of cancer to the survivor and society, meaning that we're going to decrease the cost of what it's going to take to manage their health and return to a normal active lifestyle. So the minute that we have to do a long, extensive treatment plan for an advanced lymphedema or a pretty difficult shoulder, it's going to take a lot more visits because we're dealing with something much more advanced, which is going to be more essentially billing to the insurance, more time out of the patient to come to appointments, and more copay typically. So decreasing that economic burden is also something that we're constantly considering as well. And that's a big part of what we're trying to do in physical therapy, is not let things be quite so expensive for everybody. Okay, the other thing that we want to do is we want to decrease the likelihood of stage 2 to 3 lymphedema from 30% to 6%. That's a legitimate goal. And I think that's a goal that as a population that we can be working on, and we can be working together to educate individuals in our lives to say, hey, this is a risk, but you can decrease your risk. Simple as that. Just educate, pass on the message. So next message is we want to decrease the cost of treating lymphedema. So estimated cost to manage an early stage breast cancer related lymphedema, so this is specific to breast cancer, is $636 a year. That jumps to over $3,000 a year for a more advanced stage lymphedema. So again, if we catch this quickly, it decreases the economic burden. The other thing is, again, we can decrease the prevalence of ongoing shoulder pain from 43% to 9% with early intervention. Again, just education of like, hey, did you know that you could decrease your risk of having continued shoulder dysfunction if you get that treated pretty early? I had no idea. Well, great. So just, again, pass on the word, pass on the message. And then just knowing that 50% of individuals are probably struggling with myofascial pain syndrome after their breast cancer related treatment. And so when they are complaining of pain, or like, man, my neck is still hurting, or my arm is still hurting, and pain it makes you feel tired, and you're not as likely to want to engage, and you're just not as in good of a mood. Like understanding that, I think, can be helpful to say, you know what, I just watched this presentation, and maybe this is part of what's going on. Maybe you could have trigger points that refer pain to go up into the head. Maybe this is part of your headaches. But having this type of discomfort and just inability to kind of get rid of the pain and return to living normally is something that can be helped. So don't accept it as normal. That's the biggest thing. Don't accept it as normal unless you've really, really given it your all, and we might have other things that are going on as well. So maybe some history of past surgeries, or a lot of times there might be other things that are contributing. It's not just the breast cancer. But many times we have really good results with individuals of returning to a very happy and active lifestyle. All right, so we have 3 options currently to address this topic, okay? Whether or not you have current pain or dysfunction, and if you just want to be proactive, it doesn't matter. It could be a painful situation, it could be a proactive situation, it doesn't matter. You can always come into the evaluation, into the clinic for an evaluation. Okay, we are open. We're deemed essential currently during all of the COVID stuff. We are wearing masks all the time. I'm not wearing a mask right now because I'm sitting alone in a room, but other than that, I have a mask on during the day. We are sanitizing everything to an incredible amount to make sure that we are never putting anybody at risk by coming into the clinic. So that is always the option, okay, is to come into the clinic. Okay. Number 2, okay, is you can schedule a telehealth evaluation. Caveat, not all insurances will pay for a telehealth evaluation, so you'd have to call the clinic or call your insurance company. You can always do that on your own and ask if an evaluation would be covered under telehealth services. And they'll either tell you yes or no, or we can try and help look that up. Telehealth visits, so follow-up visits, are typically being covered by most insurance companies, but the evaluation or that initial visit may or may not be. That just depends on your specific situation. Okay. The other thing is to just start with education, okay, and to come in if at some point you need to, and that's going to be the main thing. Is just start with what you've learned here and spread the word and pass it on, and help to also educate other individuals in your life or in your community or your neighbors or your friends, and just let them know, like, hey, by the way, like, it is, you don't have to accept this as normal. You can get help. There's people out there that are specifically trained in dealing with this. If you want to get a hold of us, we've got the email down here, info@premierptjax.com, and you can always send an email there. You can send an email to me, which is jess@pptjax.com. We'll go ahead, we'll put that into the comments underneath just in case you are interested in emailing me directly. That's totally fine. I'm happy to communicate with anybody and everybody, and we kind of go from there. So if there's any questions, anybody can type in messages. They could type in messages all along during any of our Facebook Live events. And even if you think of the question later, you can always type it into the comments or shoot us an email, and we'll get back to you as best as possible. So, all right. So I'm going to sign off. Oh, the other thing I was going to tell you is that we're going to be loading this onto our Facebook page under videos, as well as onto our YouTube page under Premier Physical Therapy. And so if you want to watch this later, or ask somebody else if they have interest in it, you can guide them and say, hey, look up this video I watched or that I saw, and let somebody else also learn about what's available and what's out there. Okay. All right. I will hopefully see some of you in the clinic. If not, please tell people in your lives about how much we can help. Alrighty. Bye.